Good evening. Hearty welcome to the delegates of IMA CGP CME series, webinar series on every Thursday. Respected leaders and dear friends, as you know, IMA College of General Practitioners is the oldest academic wing of Indian Medical Association. Here, IMA CGP Keralam is proud to announce this series of weekly webinar, or bringing in important updates, bringing in essentials for every day in modern medicine. That is our theme, where we provide review of basics and we bring in essential updates in various specialties so that every doctor is empowered and thereby our profession is empowered to the best. And together, let us empower every healer and let us enhance the healthcare. It is the theme of Indian Medical Association Kerala State for this year too. And we are greatly indebted to our State President, Dr. M.N. Menon, and Dr. Roy Archandran, State Secretary, for enabling us to conduct this series of program. And IMA CGP Kerala is blessed with the presence of Dr. Biju Nelson as the State Secretary of the program, apart from myself being the Director of Studies. Friends, here there are no leaders. We here are the frontline warriors of modern medicine, where we need to empower each other. And hence, we humbly request you to provide us the feedback, and where, which all topics need to be covered, which all faculty need to be brought. We are trying our best to bring in the best. And over the next 20 weeks or so, we'll be conducting this program. We are also trying to come out with a handbook for essentials of modern medicine for every doctor. In that sense, we are trying to bring out a handbook too. So join IMA CGP. It's a lifetime membership costing only 1,000 rupees. With added GST of 180 rupees, it gives you immense facilities. Okay, and please also note that the same Zoom ID and password could be used for subsequent meetings. Friends, we also have a WhatsApp channel empowering you on a daily basis, where there is self-care tips, MBBS medical basics and beyond, and there are teachers' corner on Tuesdays, and welfare matters are also brought in. And there are a lot of updates. Friends, so please do follow the WhatsApp channel at the link given, and we'll also provide the link on the chat box. And then you can always communicate with us with writing to us by IMA CGP Kerala, IMA CGP Kerala @gmail.com. Friends, let us resume the weekly webinar series of today, every Thursday at 8 p.m. with same link, same Zoom code, same passcode, and same Zoom ID. And we are also getting live streamed through YouTube, IMA Kerala Official, the link of which will be provided. But we encourage every one of you to participate. And we are encouraging anybody across the globe to participate, because, there will be some problem with the time frame and all, but we understand. But, practically, since it is in English, and we'll be, continuing in the same medium, and we will be trying to update every practitioners of modern medicine across India, if not the world. And so we'll be resuming today's program, and please, this has already been discussed. And today we are blessed with the presence of a great teacher, a medical teacher par excellence, and a non-orator, and a perfect clinician, and a true human being. Because ultimately, we being the human being, the main purpose, the main role, the most crucial role that we can play in this community, in this world, is being human. And Professor Dr. B. Jaya Prakash is known to me as a teacher, medical teacher for me during my undergraduate days. And from there, he has been a great source of energy and enthusiasm. Now, I formally welcome you all, apart from our beloved Secretary, Dr. Biju Nelson, to formally introduce our faculty of the day. Over to you, Dr. Biju Nelson.
Good evening. Director of Studies, IMA CGP, Dr. C.V. Prashant.
Dr. Biju Nelson, you are not heard.
Can you hear me? Can you hear me? Can you hear me?
Yes,
Can
yes,
you hear
yes.
me? Yeah. Director of Studies, Dr. C.V. Prashant.
Yes.
The Speaker of the day, Dr. B. Jaya Prakash. Distinguished members of IMA, colleagues and friends. It's my great pleasure and privilege to introduce today's esteemed speaker, Professor of Pulmonary Medicine and a highly respected clinician, academician, and teacher in the field of respiratory medicine. A native of Varkala, he is the HOD of, currently is the HOD of Pulmonary Medicine, Mugambia Medical College, Kanyakumari. So he was retired as the Professor of HOD, Respiratory Medicine, Alleppey. He had many fellowships in his name. The famous was his fellowship in airway diseases from McMaster University, Canada. He was the president of Academy of Pulmonary and Critical Care, Kerala. He had many orations in his name. Today, he joined us to share his experience in this important topic on COPD. On behalf of IMA CGP, I warmly welcome Dr. B. Jaya Prakash, Professor of Respiratory Medicine, for this talk. Thank you, sir.
Thank you, Dr. Biju Nelson. With immense pleasure, let us all, invite Professor B. Jaya Prakash, sir. Hearty welcome, sir. Over to you, sir. സാറിന്റെ മൊബൈലില് മ്യൂട്ട് ചെയ്യണം. മൊബൈലില് അതിലൊരു സ്പീക്കർ ഐക്കൺ ഉണ്ട്, അത് മ്യൂട്ട് ചെയ്യണം. സാറിന്റെ മൊബൈലില് സൂം കയറിയിട്ടുണ്ട്. അതിനകത്ത് ആ സൂമിന്റെ റൈറ്റ് ടോപ്പിൽ ഒരു സ്പീക്കറിന്റെ ഐക്കൺ ഉണ്ട്, അതിലൊന്ന് ക്ലിക്ക് ചെയ്താൽ കയറിയിട്ടില്ല. സാറിന്റെ പക്ഷെ 2 സൂം ID കാണുന്നുണ്ട്. സാർ മൊബൈൽ ഒന്ന് ഇതാക്കിയാൽ മതി. മൊബൈലിലെ ഇന്റർനെറ്റ് അങ്ങ് കട്ട് ചെയ്താണ്. We'll be resuming the program soon. There is some technical problem. Should be corrected. Sir. Dear friends, let me update you all about something more. Like, till the Jayaprakash sir's technical issues get sorted out, let me tell you, IMA CGP is organizing a lot of courses, which you can log into the IMA CGP website. One of the most commonly demanded, this thing is a fellow of IMA College of General Practitioners, which is popularly known as FCGP. And this FCGP is, awarded with an exam for junior doctors, whereas the FCGP will be awarded as a special honor for any doctor who complete 20 years of medical education, medical practice, 20 years of medical practice, for which that doctor has to apply to the IMA College of General Practitioners at that national headquarters. The national headquarters of IMA CGP is located at Chennai. And so I hope it is very clear. IMA College of General Practitioners offers a lot of training programs, and I will share the website link. I will share the website link of IMA CGP National Headquarters in the chat box soon during the talk. And please do make use of those facilities. And IMA CGP is a avenue for us to learn and empower ourselves. Now the problem is getting solved. Jayaprakash sir, can you hear me?
I can hear you, but I cannot share. You could not share.
Sir, from the laptop, just screen share once again, sir. Krishnan.
So he is co-host.
There is IT coordinator. Actually, I am just in front. Behind everything is supported by Mr. Krishnan. He is one of the most committed staff of Indian Medical Association. Krishnan, please help Jayaprakash sir.
I could not share. I don't know why.
So you are the co-host, sir. You can share it.
Sir, sir, can you mail me the PowerPoint presentation? I can share from here. Kindly bear with us for this technical problem. Will be resolved soon. Friends, meanwhile, I have put the WhatsApp channel link in the chat box. You can directly click on it. Then you will reach this this page. I'll show you. Now, what you see here is the IMA CGP Kerala State WhatsApp channel, where you can practically see the updates on various academic things. On various academic programs, and then you will also get some updates, some videos, some important programs, and there are a lot of updates regarding your medical practice like, it just gets disappear, though the files which we have shared 1 month before, and you will get updates on regular clinical practice where practically, on vaccination, on maybe a particular drug, on maybe particular clinical protocol, or maybe a new update on the, influenza vaccine or something like that. So you can log into with that WhatsApp channel link, which is provided there. Okay. And this is the CGP IMA Kerala State WhatsApp channel. It has around 1,000 followers, which is actually, getting day by day, picked up. Okay. Thank you. And this is the website of IMA CGP national level. You can log in at imacgpindia.com, which will provide a lot of, academic updates and CGP courses and all. Sir, presentation has arrived. I'll, start sharing the screen. Jayaprakash sir. Jayaprakash sir, can you hear me?
Yes.
Sir, I'll share the screen in a minute. We just received the presentation. See the screen, sir?
No. Yes, yes.
Sir, please start.
I can move from here, no?
I'll move, sir. Sir, I'll just get your prompt and move. Okay.
Okay. Good evening, all. Respected Dr. Prashant CV, the Director of Studies, IMA CGP Kerala, and Dr. Biju Nelson, the Secretary of IMA CGP, and all other members who have joined for this meeting, IMA members and non-members probably. So once again, good evening, and I am extremely sorry for the technical hinge. I don't know what happened in sharing the slide, but anyway, I will try to do the presentation as quickly as possible. So the topic which I am supposed to speak on today is actually chronic obstructive pulmonary disease. That is COPD, popularly called as COPD. Okay, so now I think I will start with a real case scenario. This 71-year-old male who actually started smoking at the age of 21 years. After a couple of years, no, maybe like after 5 to 10 years, he started some irritating cough and breathlessness. And he didn't care about that. And gradually he developed mild breathlessness, which was progressing. And he consulted a doctor and he advised that the smoking is causing his dry cough and mild breathlessness. So no medicine is required. You please stop smoking. But unfortunately, this gentleman didn't stop smoking and he continued smoking. Gradually, after a couple of years, the patient developed a breathlessness, even walking 100 steps. So at that point of time, he was started on medication, and inhaler medication. But he continued both inhaler medication and smoking. After a few years, actually, he developed pedal edema, desaturation, and one episode of infection has led him to hospitalization, followed which the patient was put on home oxygen therapy. So with that introduction, I will go to the rest of my presentation. Now, this COPD, now last year, 2025, we had a World COPD Day on 18th of November. And the World COPD theme was very simple. Any patient, any person, any adult who is feeling short of breath, just think of COPD. I think that message which we brought out last year during the World COPD Day was very relevant. Whatever be the cause, anyone feeling short of breath, please think of COPD because that prevalence of that disease is very high in India. Next slide. So the definition of COPD is very simple. C stands for chronic. Next slide. O stands for obstructive. P stands for pulmonary and D stands for disease. So COPD is chronic obstructive pulmonary disease. Next slide. No, Prashant asked me to talk on asthma actually first. I thought asthma is actually a frequently discussed disease. So we will discuss about it's relatively not discussed disease COPD. If you look into the difference between asthma and COPD, both are actually obstructive airway disease. Both disease, the patient or the person will feel breathless. But there are major difference between asthma and COPD. So the difference is listed in this chart. On the left side, you have asthma. On the right side, you have COPD. Remember, asthma can occur at any age group, but COPD usually occurs in the older age group after 40 or 45. And asthma patient may be a smoker, but COPD will be invariably a smoker. And asthma patient will have breathlessness, which is like an episodic breathlessness. It may comes with a trigger factor, and if you take treatment, it will control. But COPD patient, the breathing difficulty, the Shwasamattal or the breathlessness will be more of an exertional type. He will be less breathless when he is taking rest. When he exerts, the breathlessness will be more. And in looking into the pathology or pathogenesis, asthma patients will have an airway eosinophilic inflammation, but the inflammation which is present in COPD will be more of a neutrophilic inflammation. That makes in the difference in the treatment also. And one thing which is very important for asthma, which differentiates from COPD, is asthma patients have an airway obstruction or a bronchospasm, which is almost completely reversible with the treatment. But unfortunately, in COPD patient, they also have an airway obstruction, which is almost non-reversible or very poorly reversible. That's the basic difference in the airway obstruction or bronchospasm of asthma and COPD. Asthma patients will have a airway obstruction which is reversible with the treatment. COPD patients will have an airway obstruction which is irreversible, poorly reversible. And one thing which is very important again is asthma patients, because the airway obstruction is reversible and the inflammation is eosinophilic, the systemic effects or the systemic complications secondary to that disease is less with asthma and it is very high with COPD. Next slide. Next slide. Now, COPD is popularly called as, we discussed chronic obstructive pulmonary disease. Another terminology which we use is chronic obstructive airway disease. Both are actually same. But I want to say COPD is not confined to the lungs alone. As I said, COPD patients gradually other systems like heart, brain, all other organs will be kidney, all other organs will be involved if you don't control the COPD patients very early phase. So let us understand that asthma is maybe confined to the lung disease, and COPD is a disease which is not confined to the disease. Gradually, it will have systemic manifestations. Next slide. So what are the systemic manifestations? Next slide. So I said now COPD as days go on or as the disease progresses, it will involve the heart producing cardiac effects. It can produce depression in nearly half of the patient because COPD is a disease which is poorly controlling or poorly reversing with medication. So that patients will go for depression and they will have a total cachexia. Patients will have more of skeletal muscle weakening because the activity will be decreased. They will have hematological manifestations including anemia, osteoporosis, and finally heart attacks and stroke can occur in patients. That's why COPD is to be looked into in a very special manner. Next slide. All the rest of the thing which we are going to discuss or I am going to discuss will be based on a initiative called GOLD. So GOLD, what is GOLD? GOLD in relation to COPD is a global initiative for managing chronic obstructive pulmonary disease. Nearly 100 countries joined together and we formulate a very good guideline for diagnosing and managing COPD. So all the further slides or what are things which I am going to discuss further will be based on the GOLD guidelines. Next slide. Now, if you look into the prevalence of COPD globally in the world, in 1990, COPD was in the 6th position. Now COPD in 2023 become the 3rd position. Even now in the global, among other diseases, which are the common cause of kill. What are the other common causes of killers? IHD or cardiac disease, cerebrovascular disease, respiratory infection, diarrhea, other diseases. Now COPD stands in the 3rd position, which was in the 6th position in 1990. Now it is in the 3rd position. Next slide. But that is in the 3rd position. Next slide. In globally, COPD is the fourth common cause or 3rd common cause of mortality. But if you look into the Indian scenario, already COPD become the 2nd common cause for death in India. So remember, COPD is to be addressed very carefully, very efficiently. Otherwise, that still gradually become the 1st leading cause of death in India. Now it is in the 2nd leading cause of death in India. That much is the importance for COPD. And look into the numbers. More than 3 million people died of COPD in 2024. And again, more than 3.1 million people died of COPD in 2025. Equal number will be in 2026 also. So the burden of COPD is very high in India, in Kerala, and globally. So this topic will really require discussion and further understanding. Next slide. This is the definition, which is very complicated, but the left side is the classical definition, which only the postgraduates need to know. But you must understand, if you look into the definition, COPD is a common preventable and treatable disease. Don't think that this disease, even though it's an irreversible condition, we cannot treat. We can treat it. But what is important is we can prevent COPD if you reduce the smoking habit and environmental pollution. And as I said earlier, unlike asthma, the COPD patients will have a persistent irreversible airway obstruction leading to persistent symptoms. And this is usually caused by either smoking or other noxious particle or gases exposure. Next slide. Next slide. Next slide, please. No. There are different risk factors. There are different risk factors for developing COPD, but the commonest risk factor for or 90% of the COPD is caused by tobacco or cigarette smoking. Next slide. The other causes are all smokers may not develop COPD. It is actually genetically determined, and that genetic predominance has to be there to develop COPD. But remember, the commonest cause is tobacco smoking or cigarette smoking. But the other causes are if a patient has asthma which become untreated and chronic, that can gradually become a condition called asthma COPD overlap, and gradually it will lead on to COPD also. So an asthma patient, if you don't control properly, that can also lead on to COPD. Remember, environmental pollution, working in an occupational bad atmosphere can lead on to COPD. Recurrent respiratory infection can lead on to COPD. And hormone or enzyme alpha-1 antitrypsin deficiency in the body can lead on to COPD, and even a low birth weight can predispose for COPD. But remember, the three common condition which produces COPD is smoking, number 2, environmental pollution, number 3, and poorly or uncontrolled asthma. But other etiological factors are also there. I said smoking is the commonest. Next slide. Smoking is the next slide. Smoking is the commonest cause, which next slide, lead on to 90, even 70 to 90% of COPD is caused by smoking. That is giving the importance or link between smoking and COPD. Next slide. And this is one example. Now, one of the patient who is admitted to the ward, actually, he went outside to buy something. When he came back, actually, he went with permission to go outside to get a bread. Actually, when the security person checked this bread, he was hiding the BD and the matchbox inside the bread. That is the affinity to the smoke. Even if you try the best, a smoker or a COPD patient, it's very hard to remove the smoking habit. Just highlighting the association between or the habit of smoking and addiction and relation to the COPD. Next slide. So in India, there was a study which is published in NEGM and proved that one of the most common cause for developing COPD in females of India or non-smokers, those who are not smoking, the second most common or the most common cause in females in India developing COPD is biofuel exposure. You can see the picture which is showing the fumes which is coming inside the kitchen with a poor ventilation, and the varagadupu or the fuel which we are using is one of the common cause for developing COPD in females. Next slide. So we discussed the different etiology or different causes of developing COPD, starting from smoking to environment pollution to biofuel exposure, or the other fuels which we use for cooking and all. Based on the etiology, we have a different classification. For example, if there is a patient who is a smoker developing COPD, we call it as a COPD-C. C indicate cigarette smoking. If there is a patient who has a genetically dependent COPD, we call it as a COPD-G. So based on the etiology, we have a classification. I am trying to say that if a patient develop COPD due to smoking, I diagnose and classify it as COPD-C. C stands for cigarette smoking. Next slide. Next slide. And just a slide about the pathogenesis or how a patient develops COPD. If a patient smoking or exposed to environmental pollution, what happens is gradually, next slide. Next slide. Yeah. If there is genetic predisposition and the patient gets respiratory infection also frequently, finally, this will lead on to COPD. So that's a simple pathogenesis of COPD. Next slide. So this is COPD. So when a patient exposed to tobacco or other pollution, it will lead on to COPD if there is a genetic disposition and predisposition, other factors also coming. Next slide. So a slide about the pathological changes which are happening in COPD in the airways. As I said, all COPD patients will have a chronic inflammation, chronic neutrophilic inflammation. Subsequently, when they develop COPD, the airway will be filled with the mucus and mucus secretions. They will be having a lot of sputum. The airway or the bronchus will be obstructed, and gradually, because of the permanent airway obstruction, lot of air will trap inside the lung, and because of the air trapping, the lung will hyperinflate. That's why COPD patients will have a overinflated or a hyperinflated emphysematous lung. And because of this pathology, because of air trapping, hyperinflation, airway obstruction, there will be a gas exchange abnormality. We call it as VQ mismatch, and which will lead on to patient symptoms. And when the airway is persistently inflamed, the inflammation will spread from the lung into the other organs through the bloodstream, and will involve other organs. When it involves the heart, it will produce pulmonary hypertension. And as we discussed earlier, it will lead on to stroke and other all comorbidities which can occur secondary to the chronic obstructive pulmonary disease. Next slide. Next slide. And this is the histopathology. The first is, okay, the A represents the normal lung. You can see the normal beautiful alveoli which are normal. And when there is a patient with a chronic bronchitis, which is one type of COPD, chronic bronchitis, the airway will be more of thickening and there will be mucus production. In emphysema, there will be complete destruction of the alveolus and terminal bronchus, lead on to the total destruction of the lung. Next slide. Next slide. This is the electron microscopic picture of a patient with a normal lung. The first picture is the normal lung, and there is complete destruction of the airways and alveolus. Alveolus are destructing in patients with the COPD emphysema. Next slide. And now the basic diagnosis, etiology, and the symptoms we discussed. Now, when to suspect COPD in a patient? Suppose a patient coming to you, see you, and telling that I am having breathlessness which is of exertional type. You just ask whether you have exposure to any of these. Are you a smoker? Do you have any occupational exposure which is, or are you working in a polluted atmosphere? And when that patient has respiratory symptoms, especially cough and breathlessness. Next slide. Next slide. When they have symptoms of shortness of breath, chronic cough and sputum, you suspect COPD. So this is a simple way of suspecting COPD. Any patient who has a risk factor coming with a respiratory symptom, especially breathlessness and chronic cough or sputum production, just suspect COPD. And that patient, after clinical examination, you may do an X-ray, but one test is very important. Next slide. That is called spirometry. Spirometry is a simple test. It's otherwise called a pulmonary function test, which is a simple test which is free in government hospitals or may charge 200 to 300 rupees. If you do a spirometry, which will tell you or with which you can confirm the diagnosis of COPD. Next slide. So this is the spirometry. I'm not going to the detail, which is a bit difficult to understand, but a spirometry, if you do, actually spirometry is very simple. Into a machine, you just blow. And the blow, or the amount of air that you are blowing, the computer will detect how much air you are blowing. Is there any airway obstruction? And to diagnose airway obstruction, you have a parameter called FEV1 by FEC ratio. That is the one which we look into the spirometry for diagnosing COPD. When the ratio of FEV1 divided by FEC is less than 70%, you can say there is an airway obstruction. And you give a bronchodilator or a salbutamol with nebulization with an inhaler and repeat the spirometry. And if there is a reversible, the airway obstruction or less than 70% is reverting, you can call it as an asthma. If it is not reverting, it will be diagnostic of COPD. Next one, next slide. So this is the grading. As I said, when the ratio of FE1 FEC is less than 0.7 or 70%, you call it as an airway obstruction. Give a bronchodilator and do the test again. If it is not reverting, not improving, or the ratio is not improving, you can confirm COPD. And based on the value, if it is between 50 and 80%, you call it as a moderate COPD. 30 to 50%, it is severe, and very severe will be less than 30%. Next slide. And this is actually the pictorial depiction of the same thing which I mentioned. This is a normal patient where the ratio is 0.8, which is a normal ratio. In a patient with COPD, it has to be less than 70. This particular patient has 0.56. So this is diagnostic of a COPD. Next slide. So this is again the same thing which I described. Any patient with a spirometry showing a ratio FE1 divided by FEC is greater than 0.7, COPD is not there. When it is less than 0.7, you give a bronchodilator. If it is going above 0.7, it is not COPD. If, even after bronchodilator, if it is less than 0.7, it indicates a COPD. So simple. Any patient with a cough or breathlessness, with a history of with an exposure of either tobacco or any other pollution exposure, you just think of COPD. Do a simple test called spirometry or pulmonary function test. Look into the ratio, FEV1 divided by FEC ratio. If it is less than 0.7, give a bronchodilator, salbutamol or nebulization, or a 2 puff or 3 puff. And you can repeat the test again after 20 minutes. If the ratio is going above 0.7, no COPD. If it is less than 0.7, it is COPD, which can be confirmed. Next slide. Now, to assess the patient's symptoms, how much the patient's symptoms are present, you can ask the patient, but there are two scales which are available. We learned in the previous days, either MMRC scale or MMRC scale, or there is a SCAT test. SCAT means COPD assessment tool. I think this is not very important. Just I am conveying after diagnosing to assess the level of symptoms. It is mild or moderate, you can use these tools, which are actually theoretically important. Okay, next slide. Now, when you diagnose a COPD, there are a few differential diagnoses. Now, differential diagnoses are like maybe asthma, cardiac disease, or even some other disease can mimic COPD. So sometimes, usually a clinical examination, an X-ray and a pulmonary function test or a spirometry is enough for confirming the diagnosis. But when there is a confusion regarding the diagnosis, you can do a CT test, which will help you to differentiate or rule out other causes of COPD or other complications of COPD. Normally, a CT is not required, but whenever there is a confusion or whenever you suspect a complication, you can do a CT test for that. Next slide. Next slide. Now, regarding the last part, the management of COPD. So, you suspect COPD first, diagnose with a spirometry, and now you grade the dyspnea and decide on management. The management of COPD is divided into two portions. One is stable COPD or a normal COPD, how you manage. And whenever they comes with exacerbation or increased breathlessness, we call it as COPD exacerbation, how you manage. These two are important. Next slide. So I'll be talking more on the management of the normal COPD patient. Exacerbation is a different topic. We will discuss, I think, in a different session. So the aim or goal of a doctor for treating COPD are two. One is to reduce the patient's symptoms and sufferings and breathlessness. Number two, which is also very important, to reduce the future exacerbation and future events like the systemic manifestation. So when you get a COPD patient, your treatment has two goals. One, to reduce the patient's breathlessness and symptoms. Number two, to prevent exacerbation so that he will not come to the casualty and further complication like cardiac issues and other issues. Next. Now, the ideal treatment for COPD is a combination of a bronchodilator and very rarely or few percent of the cases you can give inhaled steroid. So the cornerstone or the drug which is used for the treatment of COPD is a bronchodilator. So either you can use one bronchodilator like a LABA. LABA is a long-acting beta agonist. Examples are salmeterol and formoterol. Salbutamol is a short-acting beta agonist which we are not giving usually. So you either give a long-acting beta agonist, example salmeterol or formoterol, or a long-acting muscarinic agent, that's called a LAMA. The examples are tiotropium, ipratropium, and glycopyrronium. So either a combination of a LAMA or LAMA. In selected cases, you can add inhaled steroids when the COPD is very severe. Next slide. So as I said, the treatment of COPD is bronchodilator or a bronchodilator combination. And selected cases, you can add inhaler steroid. What are the selected cases? When the patient has associated asthma, or when he has a high eosinophil count, or when the patient is not better controlled with a bronchodilator alone, you can add inhaled steroid. But inhaled steroids are not used for patients with less eosinophil count, less number of exacerbation, and if they are getting pneumonia frequently, don't use a inhaled corticosteroid. Next slide. And the best treatment, I said, is a combination of bronchodilator or combination of bronchodilator with inhaled steroid in some cases. But one thing you have to understand is patient with the COPD, because of the bronchospasm, airway trapping, they will not be able to take the inhaler deeply. So a device called a spacer, you can see this patient or this person is using an inhaler in the extreme left hand, and you can see a vessel-like thing which is attached to the mouth and into the inhaler. That is called a spacer, which is very important and very useful for a patient with COPD. So the best treatment, I would say, for a patient with COPD is a inhaler which containing bronchodilator and along with a spacer is the best treatment tool for a COPD patient. Next slide. So this is the combination, the flow chart for treating a patient. When the patient is a mild COPD, you can give a single bronchodilator. That's called Group A. Group B is a little more severe COPD where you give more than one bronchodilator. When the patient is severe or high eosinophil count or an asthma component is also there, you can use an inhaled corticosteroid also into that patient. He will fall into Group E category. Okay, next slide. Next slide. And this is regarding the treatment pharmacotherapy, but for asthma, a pharmacotherapy or inhaler may be enough. But in patient with the COPD, since the defense mechanism is poor and smoking will produce more harm, and if a patient use inhaler plus smoking, I think this inhaler will be a waste. So that treatment will be to be successful in a COPD patient. Non-pharmacological management is also very important. The most important non-pharmacological management is smoking cessation. So any patient who is diagnosed as COPD, please teach him and please encourage him to stop smoking, and you can give psychological support, moral support, even other medications also you can give for stopping smoking cessation process. Next slide. So in addition to the pharmacotherapy or inhaler containing bronchodilator and stop smoking, you have to vaccinate the patient. Now there is a protocol called adult vaccination, which is important for all patients with the COPD and other respiratory disease. There are 4 or 5 vaccines recommended for COPD, but I would say there are 2 vaccinations are very important. One is influenza vaccine. Now, as you know, influenza fever is very common nowadays. And if you vaccinate with an influenza vaccine, one vaccine which is costing only 1,000 rupees or less than that, and yearly one vaccine, and a pneumococcal vaccine, if you take one vaccine, after 5 years, you may require a booster dose, or even vaccination which doesn't require a booster dose is also available now. So any COPD patient, a vaccination with influenza vaccine and pneumococcal vaccine is very important. And if you vaccinate a COPD patient with these 2 vaccines, 60 to 70% of the infections due to virus and bacteria can be prevented. That is the importance of immunization. Next slide. Again, very important. No, patients with the COPD will be breathlessness, though they will not exert, because when they exert, when they walk, that exertion will increase the breathlessness. So what will happen? They will not exert. But if they don't exert, the COPD will increase. It's a vicious cycle. So pulmonary rehabilitation, exercise, all exercise, physical exercise and breathing exercise like pranayama, all deep breathing exercises are very useful in COPD patient. I would say this immunization rehabilitations are equally important or more important compared to comparing the pharmacotherapy. So physical exercise, breathing exercises are very important in patients with the COPD. Next slide. So when a patient has advanced COPD, sometimes what happens? The oxygen level will go down in his body. If you do a arterial blood gas, the oxygen level will be less. And the criteria is if a patient with the COPD, when the saturation is less than 80% or the arterial blood is showing a saturation, PaO2 of less than 55%, you have to give long-term oxygen therapy for that particular patient. So that is also one important treatment for COPD, in addition to the other treatment which we described. Next one. Next one. Next slide. Yeah, this is a patient, our index case. This patient was admitted to the hospital with exacerbation. He had a saturation of only 70%. So we brought the cylinder and giving oxygen. But this oxygen therapy is not for a long time. This is for a short time or a short period of 2-3 days inside the hospital. Next slide. So whenever you decide to give a long-term oxygen therapy, the most convenient, most viable thing, most economical thing will be buying an oxygen concentrator. Because if you give oxygen for 6 to 8 hours for a patient with COPD, that will be finish in few days. So refilling will be a problem. So buying a concentrator, which I think the best machine is costing only 45,000, even 25,000 rupees, you will get a machine. And if you buy a oxygen concentrator, just plug it, oxygen will come from the atmosphere. This machine will take the atmospheric oxygen, air which contain 21% oxygen, will convert into 100% and give it to the oxygen. Only power supply is required. So any COPD patient who require long-time oxygen at home, please advise to buy an oxygen concentrator, which is not very costly. Even the patient will get a current concession of 200 units from the KCBB and from the Kerala government. Only thing, the doctor has to give a certificate to the electricity board for that current concession. Next slide. So when the patient has a very severe COPD, even oxygen therapy and your drugs are not improving, there is a treatment called non-invasive ventilator. So we do a blood gas analysis or an ABG. When the carbon dioxide level is persistently more than 53 millimeters of mercury, I will decide on giving a non-invasive ventilator, which is a small machine. Next slide. This is a patient. You can see the machine, which is a small box-like thing. And even we get good this machine. We call it as BiPAP machine or NIV machine. It's costing only around 60,000 rupees, but it's a wonderful tool for a patient with a COPD, severe COPD, where the carbon dioxide level is high in the blood. So if the oxygen level is low, you give oxygen therapy. If the carbon dioxide is very high, you give BiPAP or non-invasive ventilator. Even both can be given at home, will give good improvement along with the medication. Next slide. So I again coming to the same slide, I want to stress COPD is not a press next. So COPD is not a lung disease alone. It has lot of comorbidities, lot of side effects, lot of complications. The first organ to involve is cardiac disease. Next one is depression. In my experience, nearly half of the patients of COPD are depressed because of poor response to treatment. Muscle wasting, anemia, osteoporosis, CNS complications, all are these are the complications of COPD if you don't treat the patient properly and adequately. Next slide. So I would say the lung cancer is also very high in patients with COPD. Any smoker, as you know, smoking itself can produce lung cancer. But if that patient develops COPD, that particular patient will have 4 or 5 times higher chance of developing lung cancer compared to a smoker who doesn't develop COPD. So smoking itself can cause lung cancer, but if they develop COPD, the chance of developing lung cancer is very, very, very high. Next slide. Next slide. So to conclude, I would say the prevalence of COPD is chronic pulmonary disease. The difference between COPD and asthma is COPD is having a permanent airway obstruction, which is difficult to manage. So never start smoking or prevent the situations which can develop COPD. And the prevalence of COPD is increasing globally and increasing in India also. And remember, it is the second leading cause of death in India. Airway obstruction with no or poor reversibility, the hallmark of COPD, and the main treatment is bronchodilator. Some rare cases or select cases you can add inhaled corticosteroids. Stop smoking, vaccination or immunization and rehabilitation with exercise and is very important along with your pharmacotherapy. And if you don't do that, exacerbations will come. And each exacerbation in a COPD patient, any COPD patient getting an exacerbation admitted to the hospital, we call it as a heart attack because the lung function is reducing to the tune of 7 to 11% with each exacerbation. So like heart attack, which is producing reduction in ejection fraction, this lung function is also reduced. So preventing exacerbation by treatment, by exercise and immunization is very important. And always remember, COPD is not a pulmonary disease. It is a systemic disease, have a lot of complications. Next slide. So the most important step, next slide. So the most important step is for preventing COPD is not getting diagnosed and treating. It is preventing by advising stop smoking or not to start smoking. So thank you very much for the patient hearing. I think even though we started late, I think I could finish in time by 9 o'clock. And again, once again, my apology for the technical difficulty that actually I don't know how it happened. And sorry for that.
Sir, Dear Jayaprakash sir, and as everyone will agree, it was one of the most eye-opening sessions for the every general practitioners, even that a doctor belonging to any specialty. Nowadays, we know in each one of family, we will have an elderly person. And there will be some respiratory problem. And COPD is one of the most confusing clinical picture where it is asthma, COPD, or sometimes we'll be worried about cancer. But when there would be a preventable problem, we prevent it, and manageable problem, you manage promptly. And ultimately, it is we people who is going to suffer, even as a patient. Sir, you have elaborated COPD very well. There are a few questions in the chat box and a few of them in my personal chat box. So let us have a very quick session on the question and answer session. Sir, one of the chat box question that I got is, in one of the PowerPoint slide that you shared, especially in the risk factor page, you wrote that the smoking in utero. That is, can you share a few comments on that?
Okay, actually, smoking in utero, even though directly not causing COPD, because in the uterine period, smoking will cause lot of other issues, including low birth weight, poor to gain weight after the birth and all. That particular baby born to a mother who has the habit of smoking, in future, if he exposed to a risk factor, like if he starts smoking or working in a bad environment, the chance of developing COPD is very high compared to a person who born to a mother who was not smoking. So in uterine, when the mother is smoking, it's actually the chance of developing COPD is very high.
Okay, sir. One other doubt is, you also mentioned there about e-cigarette.
Yeah.
What is your take on e-cigarette? Because nowadays it is a fashion.
Yeah. I think e-cigarette also is not to be promoted because e-cigarette are also causing the smoke actually directly going into the lung, irritating the lung and producing damages. E-cigarettes is also thought to be a cause for COPD, and e-cigarettes has other diseases in the lung also, like E-valley, like a lung injury can also occur secondary to the e-cigarette smoking. So we cannot encourage stop smoking by substituting with e-cigarettes. No, that is also a cause for developing COPD and other respiratory disease.
Thank you, sir. In the main chat box, is there any role for deriphyllin, that is theophylline, and any advantage or disadvantages of rotacap or rotahaler over the MDI?
Okay, the two questions. The first question is any role for theophylline. In the, as I said, we have a good guideline called gold guideline for managing globally for COPD. So we are actually supposed to confine to that guideline. But in that guideline, they never mentioned theophylline or deriphyllin or aminophylline anywhere in the management of COPD, either in the stable for exacerbation. But deriphyllin is a drug which I was using for the last 20-25 years. And in the practical scenario, we can use deriphyllin provided only a slow releasing, that is retarded type of tablet. So whenever the other drugs are not working, you may give in selected patients deriphyllin or theophylline in the slow releasing form. Not the plain deriphyllin or injection deriphyllin is not recommended. If at all you want to use, you can use a retarded form or a slow releasing form.
Thank you, sir. Proper techniques in measuring spirometry. How to differentiate obstruction and restriction in spirometry, and what is Tinger's sign?
Okay. I think the previous, there was a second question also, inhaler or rotahaler.
Sir.
Actually, the difference between rotahaler and inhaler is, rotahaler is a capsule which is broken and inhaled. Inhaler is in the mist form, on the smoke form. So since COPD patients have air trapping, to inhale the dry powder or the rotahaler require deep inspiratory effort. So if the patient has good inspiratory flow, good inspiratory effort, you can give rotacaps. Otherwise, inhaler is the best one, and inhaler with a spacer is the best method to give inhaler medication. The second question is regarding, can you repeat the question?
Sir, the second question is actually
spirometry.
the spirometry. How to differentiate obstruction and restriction in spirometry, and what is thinker's sign?
What is
Thinker's sign.
Huh?
Thinker's sign.
finger sign?
Thinker's sign.
Finger sign. Okay, I don't know. There is no sign. I don't know what the question. Can you explain? The first part is how to differentiate between obstruction and restriction. So the spirometry, actually the interpretation is little difficult, but I can make it very easy. When you do a spirometry, look into three values. Number one is forced vital capacity, that is FVC. Number two, FEV1 or the forced expiratory volume in the first second. And if you take the ratio between the FEV and FEC, if it is 80 or 75 to 80 is the normal ratio for a normal person. When the ratio is going below 70 or 0.7, it is obstruction. When it is going above 85 or 0.85, it is restriction. So the ratio will be, that is the ratio of FEV and FEC will be reduced in obstruction. It will be increased in restrictive lung disease. That is a simple interpretation. The other question, we have a peculiar boot-like form or a coving pattern in COPD, but the other sign I am not very aware of.
Sir, thinker's sign, I just searched. A thinker's sign, also known as Dahl sign, is a medical finding characterized by darkened, thickened patches of skin on the lower thigh and elbow. It is a physical cue that indicates a patient has severe long-standing respiratory distress, typically from advanced COPD. This is what AI gave. Maybe as not that important sign. The patient will be sitting, stooping forward. So will the patient stoop forward?
That super forward posture is there. The squatting posture is there. That will help in the breathing process. That is there. Yes.
And then what about omalizumab treatment?
Omalizumab.
Actually, they have
the severe COPD patients, we have a treatment called biologics. So biologics are they are reserved for basically for asthma patients. It is not that effective for COPD patient, but omalizumab is a biologics, which is a costly medicine, which is usually given for an asthma patient who is not controlled with other medication. Omalizumab is not recommended for COPD.
Sir, then is there any advantage of acebrophilin over darifilin?
Darifilin or theophylline is a simple bronchodilator, which is not actually recommended for COPD, but you may use in selected cases in Indian scenario. But guideline-wise, it is not recommended because theophylline has a lot of side effects. And coming to acebrophilin, acebrophilin is a weak bronchodilator. It is a mucolytic and antioxidant. So if you compare darifilin and acebrophilin, for COPD patient, acebrophilin will be better because it has a mucolytic and antioxidant property, helping expectorating sputum and may prevent secondary infection also.
Sir, what is the dosage of formoterol?
Formoterol is a long-acting beta agonist. It is either given as 6 microgram or it can give 12 micrograms also. Depends upon the situations. Usually we give 6 micrograms twice daily, but some bronchodilator is required in the high dose. You can give 12 micrograms.
Okay. Since there were some queries about IMA CGP, FCGP awarding and all, and I have provided the details in the chat box. Sir has almost, covered so extensively so that there was actually, you started off with the main question. That is the how to differentiate between asthma and COPD. Because many a time in clinical scenarios, people are quite confused about, how to differentiating between asthma and COPD. So then there is another question. Like, a previous smoker, smoking for decades, that is in Kerala scenario where there will be people, and then maybe by after reaching 60 or 70 they will quit smoking and people live for longer. The patient continue to develop breathing problem, and the patient typically will be started on some metered dose inhalers by someone, and the patient will be continuing to have recurrent respiratory issues like breathlessness, with frequent infective exacerbation. The question is that in such patients, in the history of such patients can be regarded as COPD, provided there are frequent number of infective exacerbation. So the question was a very big question. I'm trying to decipher it. The question is that, is the frequency of infective exacerbation is more in COPD or asthma? I think that is the question.
In one word answer, the number of exacerbations are more in COPD, no doubt.
Okay.
Because asthma exacerbations are usually due to either an allergy exposure or a viral exposure, viral infection. And number two, if the asthma is well controlled with the medication, a small trigger or a small infection, mild infection will not produce an exacerbation. But COPD, as such, the lung function is not normal. They are very prone for exacerbation. So COPD is the disease which has more exacerbation. And when I treat an asthma patient, my aim is to get asthma control so that he can work and do. I am not very much worried about the exacerbations if they use the treatment correctly. But COPD patients, in the lung is damaged, the defense mechanism is poor, they are prone for infections very frequently.
Sir, one last very important question, I should say, especially, towards the end of the program, you told there are rehabilitation. And the question is that you discuss, sir, you have told us about including room, that oxygen concentrator. Is there any chance of mobile oxygen units, like, like which is heard in internet and all? Is there any availability of mobile oxygen units so that patient can walk, especially elderly, in the street?
Yes, actually the oxygen concentrator which I showed the picture is for a home use.
Yeah.
It has been kept in the bedroom near the side of the patient bed. But there are portable oxygen concentrators available, chargeable, no, backup charging is there. You can charge the oxygen concentrator and it will be there for 6 to 8 hours. Chargeable are there, and you can take for a movie for 3 hours after charging, and you can take that, and a small box type is also available. So it's not an issue at all nowadays, but the cost is a little high.
Even they can go in a car.
Even they can. No, I have a patient who is a COPD patient, a bank officer, bank manager now. He unfortunately have interstitial lung disease, not COPD. And now he is using two concentrator, oxygen sources. One at home, the concentrator, and he take the chargeable one in his car. He is driving from his home to the office for 1 hour. During that time, he is using that portable concentrator, and he can charge in the car also the oxygen concentrator. And he kept another concentrator in the office in the bank. When he reached there, he is using, and he is working very comfortably. Yeah.
Thank you, sir. Thank you. Actually, decades before, you told me people living with asthma, how even that swimmer who got world record in after getting control of bronchial asthma. See, actually, people speak of doctors as gods when they relieve symptoms effectively, when they give cure to the patient. But in fact, it is the passion and the science along with the commitment which makes people call us God, if at all we are near to God. And friends, it is the only enemy in front of us is the ignorance. And ignorance is not just a curse, but it is a problem to be solved. Please help IMA CGP Kerala to spread to as many doctors as possible. Let us share this wisdom of people like Professor B. Jaya Prakash sir. We'll bring in as many faculties as possible. Let me take the opportunity to thank from the bottom of the heart Professor B. Jaya Prakash sir, an icon of medical teaching, an icon of who a good clinician should be. I'm speaking from the bottom of my heart because he's such a very good teacher and very good, clinician. And as I told you in the initial beginning itself, a human being, the key role is to being human. And we are greatly indebted to you, sir. Thank you very much, Professor B. Jaya Prakash, sir. And we thank each one of you for joining us. Kindly share the link that you have got through your WhatsApp or whichever way. Kindly follow our WhatsApp channel because Nowadays, it is not easy because we are all working. It is not easy to share to everyone on a weekly basis every day. Kindly share among yourself. Please own it up and please be there in the next Thursday session. We are discussing the very important topic, sick child. A child, identifying a sick child is very important. And the primary care of a sick child is also very important. It's not only, we need not have a regular general practice for that event. Please join us, and Professor Dr. Shija Sugunan will be joining us with that program. Thank you very much. See you all in the next Thursday. Spread the word about IMA CGP's talk series. Thank you very much. Thank you. Good night.
Thank you. Good night. Good night.
Thank you, sir. Thank you very much.